Welcome to today's session titled Tools That Heal, Core Competencies for Frontline Complex Care Providers. Before we get started, I'd like to go over a few items so you know how to participate in today's event. When you join today's webinar, you selected to either join by phone call or computer audio. If for any reason you'd like to change your selection, you can do so by accessing your audio pane in your control panel. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send your questions in at any time, and we will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce Lindsay Goldman, CEO of Grantmakers in Aging, and our moderator for today's webinar. Lindsay?
Welcome, and thank you for joining us today. I'm Lindsay Goldman, the new CEO of Grantmakers in Aging. Grantmakers in Aging is a national membership organization of philanthropies that acts as a relevant and responsive network, resource, and champion, amplifying the voices of older people and issues of aging. Our vision is a just and inclusive world where older people are fully valued, recognized, and engaged in ways that matter. We are pleased to partner with Grantmakers in Health on today's webinar. Grantmakers in Health is a nonprofit organization dedicated to helping foundations and corporate giving programs improve the health of all people. Its mission is to foster communication and collaboration among grant makers and others, and to help strengthen the grant-making community's knowledge, skills, and effectiveness. We want to thank the Seven Foundation Collaborative for their support of today's program. To improve the health outcomes and daily lives of people in America with the most complex healthcare needs, 7 foundations, including Arnold Ventures, the Commonwealth Fund, the John A. Hartford Foundation, the Milbank Memorial Fund, the Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation, are working together to accelerate health system transformation. This collaborative aims to help healthcare organizations participating in value-based payment models and adopting evidence-based interventions to improve outcomes and lower overall costs of care. Complex care is a growing field that seeks to improve health and well-being for those who have multiple chronic physical and behavioral health conditions, combined with social needs such as homelessness and unstable housing, food insecurity, lack of transportation, and others that are both caused and compounded by systemic racism and poverty. Complex care seeks to serve people with complex needs in meeting their own health and well-being goals by coordinating or integrating a wide range of services and supports. While there is increasing awareness that complex care has its own foundational knowledge, skills, and attitudes, to date, the field has not named or defined a comprehensive set of core competencies, until now. The newly released Core Competencies for Frontline Complex Care Providers, developed by the Camden Coalition's National Center for Complex Health and Social Needs and supported by the Robert Wood Johnson Foundation, standardizes and elevates the special skills and abilities required to improve the health and well-being of older people and others with complex needs. Joining us today, we have Susan Mendy, Senior Program Officer, Robert Wood Johnson Foundation, Mark Humowicki, Senior Director and General Counsel of the National Center for Complex Health and Social Needs of the Camden Coalition of Healthcare Providers, Carter Wilson, Associate Director of the National Center for Complex Health and Social Needs at the Camden Coalition of Healthcare Providers, and Dana Fondell, Associate Director, Clinical Redesign Initiatives of the Camden Coalition of Healthcare Providers. Thank you so much for being with us today. As mentioned earlier, you can enter your questions for our panelists at any time in the question box on the right side of your screen. I will collect these and read them during the question and answer portion. And we will be making the slides and audio available following the program. So first, I'm pleased to welcome Susan Mendy, who will provide some opening remarks. Susan.
Hi, good morning and good afternoon to you. pleased to be here with you today. And as Lindsay said to you, just explained a few seconds ago, the Complex Care Funders Collaborative is a group of funders, and she named the 7 organizations. And we really came together to leverage our investments and our expertise to improve care and outcomes for people facing complex medical and social needs. As you can see, the 7 organizations, the 7 funders, are actually quite different. We all have, missions of really, improving lives and health, but we have different areas of focus. Some are more focused on older adults and disabilities, some on policy, some on field building, some on social services, some on healthcare, and many other different areas of focus. And we also have quite varying levels of available funding for this very, very important population and this very important field. Those who are some of the most vulnerable amongst us, who are through often circumstances outside of their control, find themselves with a multitude of health and social needs. But we felt, as the 7 funders, that we really needed to come together on this work. I know that many of us ask our grantees to do that. We ask them to partner, we ask them to work together, we ask them to leverage each other's work and to work as thought partners. And so we felt that we should really do that, that would be a very important way to move the field further and faster. So one example of our work is one that you're going to hear quite a bit about today. It's the Blueprint for Complex Care. In this Blueprint for Complex Care, really the leaders in the complex care field recognize that, as you know, no one organization, no one field can address these very complex and overlapping issues alone, can address the causes of the conditions and systems that give rise to such poor health that this portion of our population suffers. It takes all of these diverse stakeholders coming together to create a common strategic plan, to create and support innovations and just really move the field ahead. So one of the major recommendations of the blueprint was to develop core competencies and practical tools to support their use. And that's the topic of this webinar. One thing that I really want to highlight about the work in creating this blueprint for complex care is that it engaged and put in the driver's seat those most impacted. People who are living the lives of complex needs, especially those from Black, Brown, Indigenous, disability communities, just to name a few. And I think for many of us funders, one of the growing areas of focus is equity and taking our work through an equity lens. And I think in order to do that, as many of you are, we really need to authentically partner and listen to and cede some of the power and decision making to those most impacted by the issues on which we're working. And that's very much at the core of the core competencies. That's very much at the core of the field of complex care and the field at the Complex Care Funders Collaborative. I know that at RWGF, we have invested in equity for many years, and we try to ask ourselves in all of our work, how does this impact and how does it involve and how is it led by those most impacted? And I think that that's really a focus of the field coming together, of the funders coming together. And I really thank you for your interest in and your commitment to improving the way that we fund and improving our partnership in the area of complex care. Thank you.
Hi, I'm Mark Hamalicki, and I have the distinct pleasure of leading the National Center for Complex Health and Social Needs at the Camden Coalition. Thank you, Susan. We have Susan and the Robert Wood Johnson Foundation helped us to establish the National Center 5 years ago in 2016, and have been great supporters ever since. And I want to say that the Seven Funder Collaborative has really been a terrific partnership, not only for the Camden Coalition and our National Center, but for this larger community of complex care. They really treat this as a long-term investment in developing the field and developing all the work that needs to be done to accomplish these the sort of huge goals that we all have in terms of transforming how we care for people that are from the most marginalized communities and face the most extreme needs in achieving better health. So I'll pick up right where Susan left off. The blueprint, we started working on the blueprint with Center for Healthcare Strategies and IHI in 2017, so just a year after the center was started. And we did it as a way of really trying to develop a comprehensive strategic plan for the field. We spent over a year talking with folks from all levels of the field to understand the needs. And one of the things that really stood out was the need for workforce development, the fact that there weren't enough people well-trained and well-compensated in the sort of work that is most essential to improving the lives of people with complex needs, that traditional health professions programs weren't prioritizing some of the knowledge, skills, and abilities that are essential to doing good complex care or just good care for that addresses whole person needs for this population. And so the first recommendation out of the blueprint was to develop these competencies and all the work that would come once we created the competencies. So before I jump into that story a bit, I want to just level set on some terms. So when we talk about complex care, we're really talking about a person-centered, team-based, cross-sector care for people with complex health and social needs. This can happen in a variety of settings. This can be care management. This can be integrated behavioral health inside of a primary care office. There's a range of different models, and the complex care umbrella is wide. Core competencies refer to the knowledge, skills, and attitudes needed to provide complex care. We'll talk a little bit about the workforce and who we're targeting here, and then we'll refer to domains, and Carter will refer to domains in discussing the specific competencies. That's a category of competencies, a sort of a grouping of competencies. So the next slide, we talk about our goals for what we were trying to achieve in the competencies. So our charge was to develop a set of knowledge, skills, and attitudes that are essential for frontline practitioners of complex care. We want this as a framework, in part to just define what complex care is. It's because of its breadth and multiple models that sort of fit under the umbrella of complex care. We need more definitions, more structures to be able to define what complex care is and how it is done and how it is done well. It's a guide for cross-sector collaboration, and we see the competencies really as the framework from which we can build education and training materials. Ultimately, we want to integrate them into licensing and credentialing and other sort of mechanisms that create accountability and ensure that they're being used as part of the development of the workforce. And we want organizations to be able to use them practically in their hiring, training, and assessment of their teams. Next slide. So the workforce that we develop the competencies for is wide. The unifying characteristic is that they're working on wellness-driven interactions with people with complex health and social needs. This is often happening in a team-based environment, but can happen from a variety of settings or sectors, as we mentioned. This could be care managers that are associated with a federally qualified health center. This can be a care coordinator that's associated with a health plan. This can be a nurse or a physician or the front desk person associated with a community-based program who work with people with complex health and social needs. We know that not everyone's sort of client base or patient base is exclusively people with complex health and social needs. So this is designed both for those who specialize in that, as well as it's applicable to folks that have, you know, a percentage of their patient panel are people with complex health and social needs. So it really is designed to be applicable to folks regardless of their discipline, profession, geography, population, or their specific intervention. Next slide. So being team-based and being independent of particular professions sort of sets this these core competencies apart. Most core competencies that folks see are sitting within a profession or a discipline-specific environment. So a lot of the folks we started to talk to early on were from national education associations like the NASW or the AAMC or the American Association of Colleges of Nursing, folks like that who themselves have competencies. And we set out to design these competencies to be supplemental and complementary to existing profession-based competencies, not to be in competition with them. Next slide. So when we set about this project, and we did so starting in 2019 with support from Robert Wood Johnson, and we did it in partnership with IHI and CHCS and two other organizations that we have sort of pulled together as a collaborative of leaders in the complex care field and under their sort of advice. We had a national nomination process for members of a working group. We did a lot of research and interviews looking at other competencies, talking to leaders in the field, trying to understand the full context and to bring that back to the group. We chose a group that was incredibly diverse. And so this was one of the major sort of principles that we had going into this, was that it had to be interprofessional and that it had to be inclusive of people with lived experience of complex needs. So we had 15 members, plus myself as chair. Our members spanned across professions from physician, nurse, social worker, community health worker, peer counselor, public health professional, lawyer. So we had a wide range of professions. We had 3 of our consumer scholars, which is a leadership program that we run for people with lived experience, as well as another leader in the peer recovery community out of Boston as our representatives with lived experience. We had a vice chair for lived experience and really tried to elevate the perspective and voice of people who have received the complex care services, so that none of the competencies could sort of pass muster and be ingrained in the final set of documents if it wasn't acceptable and sort of informed by the perspective of people with lived experience. And so I think that having them as part of the process was incredibly important. You can see here we had a year long in which we were discussing, sort of aligning around the competencies. Ultimately, we developed a report that was released at our conference in the fall of last year, and then have been disseminating it ever since, and actually have quickly moved into sort of the next steps around building toolkits and building curriculum to implement the competencies, because as we suspected, the competencies, once defined, created a framework that allows us to go much deeper. And I'll be talking about that towards the end of the program. Next slide. So as part of the process of developing the competencies, we really tried to engage in robust stakeholder engagement, talk to a variety of folks from thought leaders and interviews at the beginning through having draft competencies put out for the field to respond to. We held webinars and focus groups. We got survey responses on those competencies. Again, all of this is so that these competencies would reflect the general and broad view of the field and be acceptable. And I think that we've seen both in the blueprint and in this process how important that early and robust stakeholder engagement is to getting a product that is embraced and people feel reflects their values and their experience and their voice. Next slide. This really is a sort of transition slide to Carter's presentation. The wheel on the left, which looks a little bit like a Trivial Pursuit player piece, on the outside has the 5 principles of complex care that were developed as part of the blueprint. So it's person-centered, it's focused on health equity, it's cross-sector, it's team-based, and it's data-driven. And then inside are the 6 domains of competencies that Carter is going to talk about. So on the right, you have a set of application and next steps, and I will return to those at the end of the program. And so with that, I'm going to turn it over to Carter to talk about the specific domains and competencies.
Thanks, Mark. I don't know that I made the connection to the Trivial Pursuit board game before. I think we need to make a complex care board game now. Hello all, I am Carter, and I'm going to walk us through the actual competencies themselves. There are 30 of them, which is far too many for us to review on our session today. But conveniently, they're organized under 6 domains, as Mark was outlining, or groupings of the competencies. We have a slide for each domain with the competencies listed under it. I'm going to go through each slide and talk at the domain level, right? What does this domain communicate about the practice of complex care? And then for each, I will then choose a single competency, typically the last one, to use as an illustration. So let's dive in. Next slide. So this is the first of the domains. It is titled at the top, Human Complexity and Context. And this one's about understanding that the poor health and well-being has multiple and intersecting causes, right? That range from biology to racism. And that individuals receiving care, as well as their families and the care team members, live within an environment. And of course, each combination of those factors is unique, right? Each individual situation is specific to them. They have their goals, their networks, their cognitive and physical abilities, their culture and preferences, and complex care providers need to navigate all of that, and it changes by each patient that they encounter. So that is the domain, right? It's listed at the top. Then you see in the white the 3 competencies that fall under this domain. I'm going to point your attention to the last one, number 3. This competency is saying that for providers to effectively navigate the complexity in an individual's life, they got to be creative. They got to be scrappy, is the word we often use. Or, as we say in the competencies, apply tenacity, ingenuity, and divergent thinking. And they need to do this at both kind of the individual and the community level at which they're operating. All right, let's go to number 2. Next one is personal and professional commitment and ethics. Not all, but most disciplines you encounter have an ethics domain for their core competencies. In complex care, there's a recognition that the connection you build with patients is close, right? And that providers are likely to encounter challenging and often emotionally draining situations. And that requires both some internal work. So take a look at number 4. That calls for self-reflection, cultural humility, anti-racism, unconditional positive regard, but also requires external work, as in number 5, on maintaining that appropriate professional boundaries within care that is anchored in relationships. So it's navigating that tension. Let's go to the next one, number 3. The third domain is person-centered relationship-powered care. This domain recognizes that the individual receiving care directs that care, that they are the ones setting the goals as well as the limitations. But it also recognizes that the relationship with the provider and with others is how the goals are achieved and how the care plan moves forward. I think an analogy you could use is one of a sailboat, right? If the patient is the sailboat, they get to pick kind of which direction they want to set their sail, where they want to move. And it's that relationship with their provider and their teams of providers, as well as others, that create the wind, or at least strengthens the wind to help them kind of get there faster. And then if you look at the number 6 at the bottom, it's important for complex care providers to not see themselves as saviors, right? I think that's often true for people that come to this work, but we need to make sure that they recognize that they're there to support, encourage, and equip patients. And number 6 kind of gets at that last piece, the equip piece. Providers do certainly help people access the services they need. They will do things for their patients, but they also need to ensure that the patient has the tools as well as the structures necessary to succeed once they've left the program. Individuals are bound to encounter new barriers and setbacks, and we want to make sure that they are prepared for those events, those high-stake moments. All right, number 4 is integrated team collaboration, which of course is about teamwork and collaboration. We are defining team broadly here to include the patient and in most cases the family. One of the things that this domain communicates is that the doctor-led model in traditional healthcare doesn't work for people with complex needs. And so take a look at number 5, and I'll read it word for word here. Contribute to collaborative decision-making and collective leadership. This highlights the importance of lifting up the voice of all team members, including the patient. Not only do community health workers and family caregivers have the knowledge and skills to participate in decision-making and hold leadership roles, they most likely hold the closest relationship with their parents, and so with the patient, and so their voice is required for ensuring that the patient's goals and barriers are fully accounted for. All right, 5 of 6. Diverse information management, right? This is the data domain. We call it diverse information management because we recognize that the information isn't just quantitative, right? It's the story you get from the neighbor when you go on a home visit that tells you, hey, I haven't seen them come out of their house in days. Or maybe when you're in the home visit, you recognize that they don't have food in the pantry or in the fridge, right? This domain is all about the need to seek out and incorporate that information in care planning. But it goes beyond that, actually. If you look at number 5, it begins, as I'm reading it, disseminate lessons, resources, and best practices. It recognizes that all providers in complex care are still learning. We're still figuring this out about what effective care is for an individual or population. And that means we all have a responsibility, right, to share what we are learning through whatever mechanisms are available to us. And then closing us out, the 6th domain is systems, complexity, and context. So this mirrors that first domain. The first domain was human complexity and context. This is systems, complexity, and context. And it recognizes that systems are messy. They're siloed and they're not designed for the individuals with complex health and social needs, and that those shortcomings, of course, impact the daily lives of this population. And number 6 recognizes and acknowledges that structures and processes of systems and teams, while not ideal for patients, are what exist. And so practitioners need to adapt to that system. They need to be successful within those structures while also attempting to change them, again, at whatever opportunity exists for them. Once again, navigating those tensions. So that's my overview. It's a taste. It's a taste of the competencies. Again, there are 30 of them. We encourage you either through this deck or on our website to go and read all of them. But I want to just quickly touch on how we think you can use these competencies in practice right now. So we're going to go ahead into the next slide. And I'm going to go through 5 ways in practice. Those are what's on the screen. And then I'll go through 5 ways in educations that you can use these. In practice, hiring. Right? You can incorporate them into job descriptions or interview questions to articulate the knowledge, skills, and attitudes a good candidate for your care team might have. For those that are already on the team, an assessment framework. Right? Managers can use these to assess the strengths of an individual care team member as well as the team as a whole. And then either through that assessment framework or through a review of your existing training offering, you can identify where additional trainings are required. And in just a few minutes, Mark's going to come back and tell you about a tool that we're developing to help in developing those trainings. And then communication, we've already found it to be really helpful in demonstrating within and across organizations how complex care practice is different than traditional practice. The unique value that complex care teams bring to an organization and to a community, and then of course with the ultimate goal of generating additional investment in them. And then lastly, they can be tailored, right? So they would to a specific population or organization structure. They were developed as a framework to cut across those disciplines. They're discipline agnostic and setting agnostic. But they can also serve as a base for discipline or role specific competencies that align with a specific population or setting. And Dana, who's going to be on in just a moment, you'll hear what she did in the substance use disorder space with the competencies. But let's quickly first touch on the education use cases. First is curricula integration, right? Standard curriculum in most health professionals schools don't include many of these competencies, and therefore the providers are underprepared to support this population. Educators can compare their existing curricula against these competencies, identify gaps, and then fill those gaps with lectures, discussions, activities. The same is true for experiential education, perhaps even more so, right? This includes residencies, internships, fellowships. Given that these are frontline competencies, they lend themselves really well to serve as a framework for these types of initiatives. The next two are learning from people with lived experience and from cross-sector partners. We really encourage educators to bring those folks into the classroom and to present to students. And these offer an opportunity to kind of anchor those conversations in these competencies and have debriefing questions based on them. And then as in academia, same as in practice, they're a good communication tool articulating kind of the need and the difference in complex care practice compared to traditional practice. Once again, that was just a sampling. We are eager to hear your thoughts on the competencies themselves and how they can be utilized. But for now, I will hand it over to Dana to share a little bit about how she has been using them.
Thanks, Carter. Hi, I'm Dana Fondal. I am, my background is in nursing, but my current work focuses a lot on improvements in pilots, workflows, and then training and workforce development for folks working in the harm reduction, substance use, and behavioral health spaces. So you can go to the next slide. So I'm going to tell you all a little bit about a project where we were invited, or asked rather, to help partner with a project that really allowed us to actually put these core competencies into practice and work through an activation ourselves, which has been a wonderful learning experience, both for our local partners, as well as kind of thinking about how this contributes to the broader knowledge about how these core competencies can be useful. So we were asked to work with two different substance use disorder navigation programs across New Jersey to identify core competencies and workforce development needs and opportunities for a couple different roles within the substance use navigation space. And this was an interesting situation because while the roles were defined, they'd been filled by individuals with a variety of different backgrounds. And while the programs had an overall unifying structure, they'd really adapted to meet the local needs. So kind of balancing that statewide program, but a lot of local implementations. So it was an interesting opportunity for us to look at how do we really bring together some core aspects around this work while also maintaining flexibility that acknowledged the work and expertise that had already been developed for each local context. So first of all, we can go to the next slide. So first of all, it's important to acknowledge that we didn't start out assuming that we would use the core competencies for complex care. We had a pretty good idea that they would be useful, but they were still being finalized when we started this program. And so we wanted to really make sure that we weren't just forcing this on a program, but that they actually were useful to the folks on the ground and that they represented the needs that were there. So we dug into a couple of key research questions and solicited information from partners, from stakeholders on the governmental side, from key experts across the state of New Jersey, as well as people with lived experience, both working in substance use disorder organizations, as well as individuals who've gone through the program. And we found that by going through this process, we identified a number of themes through all of that. And when we compared those to the core competencies for complex care, we found a lot of alignment. We actually didn't find any theme that had emerged organically that didn't fit under one of the core competencies for complex care. So that was really an interesting finding for us, and it really kind of confirmed for us that these complex care core competencies are a broad umbrella that really are wide enough to kind of encompass some of the different nuances of disease or program-specific needs. So next, we used those core competencies that we'd identified as the broad umbrellas to then further build out some of those specific functional competencies that represented the day-to-day activities done by the people in these roles. And then we did some slight language adjustments to make, based on advice that we received from our stakeholder advisory group. And then finally, and this is the big one that I am living and breathing constantly right now, is that we identified training and supports and then have begun activating training and tools to help support these programs in really being able to consistently achieve these competencies and integrate them into their work. So we can go to the next slide. This is just a quick example of kind of the process that we came up with. So we ended up, speaking to Carter's statement about tailoring the competencies, we ended up choosing 14 of the 30 competencies, but we made sure, and this was, again, it matched with what we saw in the data, it really represented core competencies from across all 6 of those domains. And this slide shows an example about how we modified the language slightly from one of the core competencies within the person-centered care domain. And this really helped us articulate the shared value and the approach across the different roles that we were developing core competencies for, while allowing us to customize slightly different functional competencies that were really specific to the setting that they were working in and the focused goals of their particular part of the intervention. We can go to the next slide. As we went through this process, I kind of said at the beginning, we were balancing that, like, how do we serve the whole program while also acknowledge the needs? That was really a theme that we kept coming back to throughout this whole process. So how did we balance consistency and values with the program and roles specific needs? And we kind of talked about this as our own version of meeting programs where they're at. So we talk a lot about meeting patients where they're at. We realized we needed to do the same thing with our partners. And this aspect and this approach really resonated with the governmental partners that we were working with. And as we've begun activating these trainings, as well as starting to apply the core competencies to other trainings that we do in this space, we've really found that this theme of that balance, as well as a couple other things, consistently are coming up around some of these different health systems, governmental partners we're working with, and other educational stakeholders. So if we go to the last slide, or the next slide, I just wanted to highlight some of the themes that have emerged so far as we've been activating these competencies. So as Mark described, the core competencies were designed to apply to all team members and really have a lot of language that reinforces team-based care. So we're seeing a growing focus of this from per member per month value-based contracts that different partners are engaging in with managed care organizations, increasing use and integration of patient navigators and case managers into care teams. There's a growing focus on multidisciplinary approaches to complex care, whether that's around a specific chronic disease state or around a specific broader population, like in the geriatric community. And these core competencies were really designed to be applicable across all roles. And so our partners have really resonated with the fact that they can have some language that applies to all members of the care team. Another thing that we found has been really useful is that as these different programs, these team-based programs emerge, not every program is staffed in the exact same way. So you might have someone that's called a case manager across a number of different programs, but that person might have a background as a case manager, as a social worker, as a nurse case manager. And we found that these complex care core competencies have really resonated because they are something that is kind of background and training agnostic and can be customized again to whoever is filling that particular role. And this is something that's been especially important in our New Jersey context around programs that are in response to the opioid epidemic and other kind of public health emergencies, where the state is really trying to get extra support to fill a certain role of navigation and case management. And different communities have been able to design programs that better meet their needs. And so these kind of role-specific core competencies versus licensure-specific core competencies have been a key part for the state and other partners' ability to feel like they're setting some shared expectations, some shared values, some shared requirements, while also giving local partners the flexibility to bring on who makes sense in their context. Another thing that is important to highlight is that more and more programs are really acknowledging the fact that healthcare spans healthcare systems, social service settings, the community, the family unit, and the language and different values that are represented within these core competencies really resonate with the workforce development professionals that are trying to instill those values across their teams. And then the other thing is that we found that these core competencies, like there's specific active language around consumer voice, around stigma, around looking at bias that happens at the individual and systemic levels. And I think a lot of different organizations are really trying to figure out what that looks like within their care setting or within, and these core competencies provided a lot of language that resonated with different partners. And finally, what we've heard a lot is that these specific core competencies are really helping put values into practice. I'm going to say a little bit more about that. I think in healthcare, we talk a lot about things like trauma-informed care and harm reduction and being person-centered. And these core competencies named specific behaviors and specific knowledge areas and specific attitudes that really brought those broader concepts to life and put them in a more specific way or specific language. And then they also incorporated other evidence-based approaches. So the core competencies are acknowledging that there's a lot of other evidence-based practices in that other agencies have developed, that things like motivational interviewing, things like harm reduction, and I think they do a good job naming other evidence-based practices that our partners are familiar with and want to integrate into care. So we found that this is a pretty good, and as I said before, a broad umbrella that really helps them push forward a number of different priorities under kind of one initiative. So I just talked a lot. I know Mark is going to wrap it up, but I'm happy to answer questions at the end.
Great, thanks, Dana. And I think her last slide really summarizes sort of the broader reception that we've heard from folks. As I said, we released these competencies at our conference in October, and starting with at that moment, even leading up to that moment, we were getting interest from health profession schools, from national associations, from organizations that are leaders in complex care, in how to take these sort of somewhat abstract competencies, just the framework of the competencies, and really move them into action. And so we have been just very surprised and excited by all the ways in which partners are taking them and starting to use them. So we quickly saw an opportunity to take the competencies and turn them into a training and education toolkit, because we saw that there were health schools and organizations that were reworking their own curriculum, their own training programs using the competencies. So we brought them together as a learning collaborative. We met a few times, we pulled together resources, and now we're getting ready to publish 2 toolkits, one for education, one for practice, taking the competencies and really translating them into training and education resources. We also, and that was sponsored by the SCAN Foundation, really came out of this 7F collaborative. We also have been talking with SCAN and Robert Wood Johnson about building out a set of curriculum to put these competencies into action. So we're excited to move that forward. We envision the possibility of one or more certificates in complex care that really allow individuals to take a set of courses, be sort of measured in that, and then be able to state, I am competent in, I have training in complex care that sets them aside. And as Dana sort of described, we're seeing appetite for this from government. We see it from health plans. We see this from a lot of different potential sort of consumers of this curriculum, the need for really high quality training. So we're excited to move that forward. And, you know, I think we are also continue to have conversations with the professional associations who are often taking our competencies and reviewing them as part of their normal process of reviewing their own competencies and updating them. And we're starting to see, not only do we get endorsement or support from more than a dozen professional organizations when the competencies came out, but now we're starting to see them actually start to use the competencies to update their own competencies. So as this gets integrated into professions, into industry standards, there's even more potential for broad adoption. So with that, I will close, and I think we have time for questions from the audience. I'll pass it back to Lindsay.
Thank you so much. If all of our presenters can please turn their cameras back on, we'll answer some questions. Okay, so my first question is, if a health system wanted to start incorporating some of these competencies, what are the first steps? And most importantly for our audience, how might a funder support those first steps? I'll throw that out to anyone who wants to answer.
Yeah, I mean, I feel like Dana can talk about some of the really practical step-to-step pieces, but I think, you know, to the second part, like I think this clearly requires dedicated time and work and resources. So, you know, a grant to a health system that really wanted to incorporate these into their own standards and their own training processes, I think could be incredibly beneficial. But Dana, do you want to talk to sort of that practical step-by-step process of how a health system would incorporate?
Yeah, I'm happy to, Mark, but I would, you know, I think one of the very practical aspects is exactly what you said, is kind of acknowledging the cost, specifically the cost of staff time. So there is always a balance of what time can you pull away from patient care that I think health systems are really having to look at when they're looking at system-wide initiatives and trainings. And often those trainings get pushed to before clinic hours, during the lunch hour, even though patient services might run over. So thinking about, as a funder, you know, what is the amount of money, or how do you price things to actually buy clinical time for the health system? You know, and maybe it's at a reduced rate, maybe it's, you know, there's different ways of structuring it, but I think just acknowledging that any time spent in training is time spent away from billable services for a lot of different providers, and thinking about how do you adequately make sure that a system can really dedicate that time. Within the health system, I think that the number one thing would be kind of coming up with what are those priorities. I'm thinking about what's the opportunity to maybe do a little bit more of a phased approach. So as Carter was saying, you know, and talking about, these were designed to be tailored. Like, there was the acknowledgement of saying, like, these are broad. We think all of these are valuable. How are they valuable for your setting? So I think really spending a little bit of that time in conversation with key stakeholders within the organization to say, which of these do we want to start with, and how do we want to sequence this approach and roll out? The final thing I would say is that, you know, I think we see this in a lot of our different trainings and works. We're big believers in the train the trainer model, big believers in working closely with key stakeholders. So I think, you know, a health system would want to identify a kind of change team that would maybe work more closely kind of with the core competencies, that might be engaging in some additional training, some additional coaching from different experts in the field, to then be prepared to kind of do that ongoing support and be those internal champions within the organization.
And I would just add,
go ahead.
I would just want to say, as part of that tailoring, it should include bringing in the voice of your own community. So in these toolkits, we're going to have patient stories that are real stories that come from communities, but every community is different. And for it to really hit home, you need to be pulling from the voice of your own community. And so making sure that you build that function into your training programs.
So recognizing the value of multidisciplinary teams in addressing the health and well-being needs of people with complex health needs. How do you establish physician champions of the model without centering the model on the physician?
That's a great question, and I think that we have seen a number of physician champions. We had them on our working group who are firm believers in the team approach, who are endlessly frustrated with the cycle of 15-minute appointments where they don't get to all the things that they need to get to, and they feel like, you know, a rat in a maze. And so, you know, I think physicians are often the most important champions of team-based care, where there's an understanding that physicians have a certain set of abilities and competencies in terms of diagnosis, in terms of prescription, in terms of certain elements of the healthcare process that only they can do. And then there's so much more that needs doing, that a high-functioning team that is able to spend more time with certain patients and take on domains of care that are not in the sort of that sweet spot for the physician, makes for the best kind of care. And so we see that sort of championing by physicians. I think physicians that have that team mentality are attracted to complex care. We had some of our physicians in the working group talked about what a satisfying interprofessional experience just the development of the competencies themselves were, because of the power of these different perspectives and backgrounds that people brought to the process.
Yeah, I don't think the limitation is their buy-in, right? I think they're enthusiastic for this. They want a strong team around them. It's capacity, right? It's can they take time to undergo the training? What we don't want to happen is that all other team members are trained in a framework and a language, and the providers left out because they couldn't attend the training. So that's the hurdle we need to overcome, not their kind of support for it.
Thank you. Well, we're getting to the end of our hour, so I want to close by asking all of the panelists for their final words of wisdom. What's one key takeaway that you'd like to leave us with? And I'll start with you, Mark.
Yeah, I think that one key takeaway is just the importance of process to the final product. So the fact that we spent a year developing this, that we elevated the voices of people with lived experience the way in which we did, and that we worked towards consensus and functioned as an interprofessional team in the development of competencies around teaming, all led to a product that has been embraced and sort of reflects all of that. So process is just as important as outcome.
Thank you. Carter.
Sure, I would advise folks not shy away from the systems complexity competencies, right? So there's that last domain. There are likely the competencies that are not currently being trained on, right? Because some of them are bold assertions, and I'll read one more competency for you. This is number 4 in the systems complexity domain. It says, use collective power, privilege, and access to question the status quo and advocate for policy change, right? That's a bold assertion, right? And I'm saying lean into these, and it's leaning into these for 2 reasons. One, because it's important for the work, but it's also important for the frontline providers, right? Like when we released the competency statements, we did receive some feedback that these felt out of scope for frontline practice, but we also heard the most enthusiasm about these, right? This is hard work, and many of the frontline providers that are coming to this type of work are social justice focused, right? And so training on practicing these skills can help connect them to a larger kind of systems change issues, which both improves those efforts and improves provider satisfaction.
Thank you. And Dana.
Thank you. I very much agree with what Mark and Carter said, but for the sake of just talking about something a little different, I think it was really amazing to me how much these resonated with frontline staff as we were activating it, and how much language they brought to naming some of the things that people spend a lot of time doing, but might be, you know, a short line in their job description. So it's something about making referrals. And these core competencies for complex care talk about how much that goes into building the relationship. Per Carter's last point about the systems complexity, it's all these different systems that they have to understand. There's the following through with different referrals across all these different sectors. So I think that while there was some complexity, and I think, you know, balancing how does this not get overwhelming, you know, how does this resonate with the frontline staff, but also acknowledging that these are really talking about a lot of things that people do day to day that might not be explicitly acknowledged by the health system. So I think there's a lot of opportunity in that, and in just showing that you see and that you honor and that you want to provide additional support to these things that people are scrambling to try to do because they're really trying to create holistic services around a patient. So I think there was a lot of energy that came from just naming a lot of these different aspects and telling people that we wanted to provide additional support to them as they're trying to achieve these goals.
Thank you so much. This was a really interesting and insightful session. I want to thank Susan Mendy, Mark Humowicki, Carter Wilson, and Dana Fondell for being with us today. I'd also like to thank the Seven Foundation Collaborative, Arnold Ventures, the Commonwealth Fund, the John A. Hartford Foundation, the Peterson Center on Healthcare, Robert Wood Johnson Foundation, the SCAN Foundation, and the Milbank Memorial Fund for their support of today's program, as well as Grantmakers in Health for their partnership. We will be making today's presentation available to anyone who wishes to view it later, including the slides and the audio, so please watch for an email to be sent within a few days. We have another webinar coming up this week on May 13th, Aging Policy and the Biden Administration, Opportunities for Philanthropy and Advocacy. You can learn more and register at our website, giaging.org. Please follow us on Twitter, Facebook, and our new LinkedIn page. And please complete the brief survey to help us improve our programming. That survey will appear on your screen as soon as the program ends. Finally, thank you all for participating in our webinar today. Please be well.